Today we are demonstrating a case of tumor debulking. I am joined here with Dr. Ankur and Dr. Sharon, who are IP fellows, and Dr. Venkatesh, who is the anesthetist for our case. We have a 52-year-old female who presented to the emergency with complaints of stridor since 2 days. Imaging showed a tumor in the distal trachea, which was causing near total obstruction of the trachea arising from the right wall. We will start with check bronchoscopy using a thin scope, passing through the vocal cords. We can see a tumor at the distal trachea. Lumen is compromised. Passing the scope, beyond the tumor we can see the left main bronchus. There is infiltration on the medial wall of the left main bronchus. This is the carina which is splayed. This is the right main bronchus. At the secondary carina we can see tumor ingrowth. We will debulk the tumor using a snare with rigid bronchoscopy. We will intubate using a 9 mm rigid bronchoscopic barrel. This is the first landmark, uvula. This is the second landmark, epiglottis. Use the bevel to lift the epiglottis. Once you see the vocal cord, slowly advance the rigid bronchoscopic barrel by turning the bevel. Much. Okay, start. We will use a snare to debulk the tumor. Slowly open.
Opening now.
Open. 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 Slowly close.
Closing now.
Close. 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 Close.
Fully closing.
Close. Slowly close.
Fully closing.
Okay. We will use a 1.7 mm cryoprobe to extract the tumor that is snared. Because this is a broad based tumor, snaring again will not help. It is better to use the bevel of the rigid bronchoscope to cut through the tumor tissue. Here we are trying to use the edge of the bevel to cut through the tumor tissue. The barrel also helps in tamponade when there is bleeding from the base of the tumor. We'll cut a bit more of the tumor. So here we can see a detached part of the tumor, but it is also very important at this point that the tumor that is debulked should not uh, obstruct the airway. We'll use the flexible bronchoscope with 1.7 mm cryoprobe through the working channel and try to remove the debulked tissue which is obstructing the airway. The tumor bit also can be removed using rigid bronchoscopic forceps. We can see that a bigger chunk of tumor is still left in the airway. We'll use cryoprobe again to extract it. There is some bleed from the base of the tumor. Always make sure to clean the airways. We can see here that a bit of tumor is still left and it is obstructing the right main bronchus. The remaining part of the procedure will be demonstrated by Dr. Harikishan. We are going to use rigid bronchoscopic barrel to debulk more tumor tissue. So whenever we are using the rigid barrel onto one side of the airway, either into the right main bronchus or left main bronchus, maintaining of axis is very important. When the barrel is advanced into the right main bronchus, we have to move the head of the patient towards the left. So we can see that the part of the tumor has been cut using the rigid barrel. That is a part of the tissue that has been cut using the barrel. So the advantage with rigid barrel is that if there is bleed from the base of the tumor, we can use the barrel to tamponade. We can see that the lumen is better compared to before, and we can clearly visualize both the right main bronchus and the left main bronchus opening. Also, this was the ingrowth we visualized at the secondary carina. Mostly it is from the right hilar lymph node, looks like an aggressive form of malignancy. We'll try to snare that part of the tumor using electrocautery. Most important thing is the coordination between the person assisting and opening the loop and the operator. So form a small loop and try to use the snare to loop it around the tumor, and while closing the snare, a resistance is felt by the assistant, and once the resistance is felt, that has to be communicated with the operator, and the operator activates the yellow foot pedal where we have set the endocut Q mode, and it cuts and coagulates the tissue at the same time. Here we have changed over to a bigger size barrel, and it helps in serial dilatation and coring of the tumor. So we can see here that the cartilage is visualized. The tumor has infiltrated and damaged the tracheal cartilage, and usually once the tracheal cartilage is damaged, the lumen cannot be held. So usually these kind of patients require a stent to keep the lumen open. Always make sure that the FiO2 is less than 40 whenever hot therapy is used inside the airways. We always have to make sure that we communicate with our anesthetist. We have achieved a good lumen, and we'll extubate the rigid bronchoscope and change over to the LMA. This is the check bronchoscopy that was done 3 days later. We can visualize here that the airway is narrowed at the lower part, and that is more towards the right side, and we can visualize the base of the tumor. We can see that the base of the tumor that was charred is now replaced with a necrotic slough. The plan here is to start the patient on chemotherapy and also assess with a surveillance bronchoscopy regarding the requirement of airway stent, and if she has to go for a stent because of the proximity of the lesion to the carina, she will require a Y stent. The histopathology of the tumor debulk confirmed malignancy of adenosquamous type. This completes tumor debulking in a case of central airway obstruction due to lower tracheal mass. Thank you.